Hello, everyone. Good morning, good afternoon, good evening, wherever you are. Thank you so much for joining this exciting session that we have for you today as part of the Financial Inclusion Week. My name is Nicole Speaker, and I'm the CEO of Farm Access Group. I will be the moderator of this event, where we will be discussing with our panelists and hopefully also with you, the audience, on the role that mobile and digital technology plays in driving financial inclusion and increasing access to quality healthcare, especially for marginalized individuals and groups. I really am excited about the following panelists that I have in my panel to discuss this. First of all, Mohamed Al-Mafazy, who is the head of the ICT unit from the Ministry of Health in Zanzibar. Second is Amaechi Ndili, the chairman of CarePay Nigeria. Third is Dorien Mulder, investment manager of the Medical Credit Fund. And fourth is Thomas Wiechers, assistant director of FSD Africa. And that makes us a very diverse and international group. And I'm excited about discussing with all of you today. So I'm going to start and dive right into the panel discussion. And Mohamed, I'm going to start with you and asking you, from your experience and in your capacity of head of ICT unit at the Ministry of Health in Zanzibar, how do you think digital technology can contribute to the great plans that the Zanzibar government has in driving universal healthcare coverage? Maybe you can describe some of the ways that you and your partners are using technology in that approach. Over to you, please.
Thank you so much. Thank you, everyone. Yes, let me go straight to the answer. The digital technology, if properly implemented, can contribute to the universal healthcare coverage. As we know, Zanzibar, like many other countries, is still struggling with shortage of health workers, specifically medical doctors and medical specialists. The Ministry of Health Zanzibar is planning to use digital technologies such as telemedicine to provide specialized services to underserved communities. Most of them are living at villages so Ministry of Health Zanzibar is planning to extend the use of digital tools to early screening and diagnosis, prediction of diseases, big data analytics, understand disease pattern, disease surveillance and response, and thus we believe will have great potential to transform health system in Zanzibar. Furthermore, Ministry of Health is planning to use digital solutions for planning and equitable allocation of financial and human resources. So the use of health insurance management and reimbursement so as to address the health financing challenges that the currently country is struggling on. Thank you so much.
Thank you, Mohamed. That's a very clear vision of you and your government in the use of mobile and digital, really about engaging in data and information, which is the basis of any good universal healthcare coverage scheme. But we also know that when it comes to healthcare and affordable healthcare, there's often a lack of financing in the countries that we all work in. Amaechi, maybe moving over to you. I know your company is playing a key role in using technology to actually mobilize healthcare financing for health. Can you tell us a little bit about the progress you have made, but also your ambitions and challenges in meeting these needs? Over to you, please.
Absolutely. Thank you so much, Nicole. I think that perhaps the first place to start is to debunk the theory that there is a lack of financing. Okay, indeed there is a lack of financing. The issue usually with financing is that lack of financing tends to be more of a symptom than a cause. Okay, and that if you are going to get financing into any sector, whether it's healthcare or other sectors, then you have to address the root cause of why finance or capital doesn't flow into those markets. And fundamentally at issue is usually one of trust and faith in the system. And that where there is a lack of transparency and a lack of trust, a lack of knowledge, a lack of data, for which capital uses or utilizes these things to make capital allocation and investment flow decisions, then you're bound to have a problem with capital financing. That's really the issue at stake. And therefore, what CarePay is focused on within the healthcare space is to use existing technologies and the convergence of these technologies to create a system that allows for transparency, allows for trust and faith for all the participants in the system, in the healthcare ecosystem, to transact on a more transparent and open basis, and to use the data that is then that then comes out of all the interactions to apply even further technologies such as artificial intelligence, etc., to allow for smarter investment decisions by all participants in the industry. And I think that fundamentally at stake with respect to the healthcare ecosystem in our part of the world is this. And what CarePay is doing is using technology to create a platform that allows for beneficiaries, for example, to interact almost on a risk-free, documentable basis with their payers and their providers, for providers to process claims, and the transparency of those claims is clear both to even the beneficiary, the payer, and the provider. And all these transparencies, okay, should actually help to elevate the interactions, the quality of interactions, and to document those interactions, and then allow for capital to flow into the industry, both on the demand side and on the supply side. And if capital flows into those two, then I think you're going to see vast improvements in the quality of care, as well as a dispersion of access across all stratas of the economy. And that's really where CarePay is playing at. I'm happy to go into a little bit more detail later, but that's really where we're at.
Thanks so much, Amaechi. And you're touching upon very important aspects: trust, transparency, and accountabilities. These are, in fact, issues that are often hampering investments in universal healthcare coverage. And you already mentioned, importantly, that this is not only about demand financing, but also on supply financing. So I'm really excited that I have an expert on the issue of financing healthcare facilities in UHC. Dorien, you are an investment manager in medical credit funds, and you are the first and only really impact fund that is financing healthcare SMEs all the way down to very small healthcare facilities. Can you explain a little bit how you do this and what role it drives in financial inclusion?
Thank you very much, Nicole. We've been working in this field for about 10 years now. And 10 years ago, we started because we realized we were working on improving quality for people to access more quality care. And a lot of the care in Africa is actually provided by private healthcare providers. And these private providers are small companies. They're run by a doctor or nurse, and they do not necessarily have financial training or background. And what we realized is that they have difficulty accessing the financing they need to improve that quality and to make that care better and scale, also to make it more available to more people. Because there's important reasons for it. One is that they're not financially literate, and the other one is that they might not have the collateral needed or required by banks. That banks find it difficult to finance healthcare providers because it's a complex sector. It has dynamics that they are not familiar to. So that's why we started to make financing available for these healthcare facilities, to allow them to improve their quality by providing flexible financing, by holding their hand and seeing what's possible in financing them. And also, as Amaechi says, by creating the trust and making financing more transparent and proving to the world that financing is possible. We finance around 2,000 health SMEs across Western and Eastern Africa, with a repayment rate that is close to 95% at the moment, even after COVID. So we are making the case that investing in healthcare is possible, and we hope many will follow.
Thanks so much, Dorien. Great examples and very innovative approach that I know just yesterday won an award. So congratulations to you and the team for that as well. So we learn about how healthcare financing, both on demand and supply sides, are interlinked, and making sure that financial inclusion is part of universal healthcare coverage is essential. Thomas, maybe moving over to you. FSD is all about financial inclusion. What is your role as an organization in promoting this, and what have been key lessons learned in your work up to now when it comes to access to healthcare services?
Yeah, thank you. So as FSD Africa, we work with and through the financial sector to achieve improvements, positive outcomes in the health sector and many other sectors. And I'd really actually like to echo a few things that have been said already, but of course I look at it very much from the financial sector perspective. So first of all, universal health coverage, of course, has as its one of its big challenge the financing question. Yeah? And there is very obviously a role both for public and private financing of healthcare. And even in the public side, so on the public side, so when I think about national health insurance schemes, for example, good standards of financial management, of application or combination of financial instruments is required. And the private sector, at the very least, could and should play a role here in transferring that knowledge. But of course, the more advanced healthcare financing systems that we see across the world, they really combine public and private financial instruments. And I think that's already one lesson, that there is a role both for public public finance and for private financial institutions. Now, universal health coverage, of course, also means that even the informal sector, and actually in particular the informal sector and low-income sector, should be included. And that informality and low-income aspect of it already tells you that there is a need for high efficiency through digital tools, for example, and for innovation that allows people even without an address, perhaps, to get access to financial instruments that they can use for accessing healthcare. Now, one of the very key lessons that we identified when we looked at our experience in health financing and our future work in health financing is actually what Amaechi and Dorien already alluded to. It's transparency and data. Yeah, when it comes to private finance to actually invest in healthcare facilities, or private insurers to provide health insurance to low-income people, there is always the question of standards and transparency. Standards as to can insurers really trust that good healthcare has been delivered and actually good health outcomes have been achieved. And for investors, the transparency that what the revenue model has been calculated as is really fulfilled in terms of, for example, a public health insurance scheme actually paying for the services timely and to the amounts that were promised and form the basis of that revenue model. So that is very, very important.
Thanks so much, Thomas. Again, important points being raised: transparency, how data can play a role in this, and accountability, and creating trust and an enabling environment for investments in demand and supply side of UHC. But it raises an important point, because a lot of these innovations, when it comes to digital technology, often come from the private sector. And as a government, first of all, this may not be necessarily a niche that people are familiar with. Fortunately, we have Mohamed in this panel who's going to talk more about it. But Mohamed, what I'm keen to learn from you is how can governments find a balance in adopting these technologies that may come from the private sector, create an enabling environment to stimulate uptake, while at the same time ensuring the rights of individuals and patients, especially when it comes to data protection, but also how a government can adopt these mainly private initiatives without running a risk that companies start overcharging and making UHC models too expensive to manage. So I'm very keen to hear your thoughts and maybe some experience around this. Over to you, Mohamed.
Thank you so much. First of all, Zanzibar has developed her first digital health strategy as a strategic document to guide planning, implementation, and use of digital health innovations. The strategy stipulates a governance framework to support implementation whereby various stakeholders, including those from private sectors, were well involved. On the other hand, the government has developed a fast and reliable fiber optic network throughout the island connectivity, whereby can be used by both private and government institutions. We also have ICT government policy, which supports innovation. On the other hand, the protection of patient rights, including individual data, is among our biggest concern, where one of the initiatives in the digital health strategy is the data sharing and protection framework, which is now under development. We are currently working in a legal and regulatory framework to further embrace digital innovation, including from private sectors. Thank you so much.
Yeah, maybe if I can ask a follow-up question, Mohamed, because I think these are some great examples. You started as a government in setting this digital health policy framework, which is, I think, a great way of starting engaging with partners. But on the issue of contracting, typically a lot of your tendering laws are based on bricks and mortar or buying ultrasounds. As a government, are you thinking about how to deal with purchasing software and technology? Keen to hear your thoughts.
Well, about tendering, we as government, we have procurement procedures that has regulations. Unfortunately, regarding to the kinds of different machines and equipments, we are still having some issues regarding to the map and the types of equipments. And the problem is that we are looking at the equipment that is going to be supported in terms of maintenance, and you need to have technicians which they can be able to first correct blue maintenance, include corrective and preventive maintenance. So we still have issues in that area, but we are looking at the way we can address those issues. We have just started with development and implementation of digital health strategy. We know that we still have so many issues to be aligned together, but as starting, I think is not bad start. Thank you so much.
No, and I think Zanzibar is a great example on how to engage in that dialogue. I think it's nice to see that you are open for this, you're recognizing where the challenges are, and working with your partners to address this in a contextual framework that everybody can use and refer to. Because that makes me ask the question to Amaechi. Actually, you are a private sector entity with CarePay, and there can be a perception that you are all in it for the money. You are not interested to healthcare coverage, especially for the poor, and that this may in fact be hampering. So, how can you share some of the examples of CarePay, how you have been working in Nigeria to making sure that technology is actually helping those who are previously excluded? Keen to hear your experiences.
Yeah, thank you, Nicole. I'm going to make 3 points to try to address your question. And then within the first point, I think I'll make three very subtle sub-points. Okay, so the overall points that I do want to make is that, yes, CarePay is a private sector company, but that CarePay and a whole host of other companies, not just CarePay, seek to operate at the intersection of capital and social good. Okay, and that the two are not mutually exclusive. You can do good business, create profitable outcomes for all your stakeholders, including for the general public. So that's the first point that I think is necessary to make. The second point that I think that is necessary to make is more within the context in which we operate, say, in CarePay Nigeria and potentially a lot of other African countries. I think it's a painful point to make, but I'm going to make it anyway, that the trend has been that in our parts of the world, we are seeing collapses or degradation of markets for public goods. So healthcare, of course, is a public good. Education is a public good. Security is a public good. And we are seeing consistently that these things over time are degrading, and that the private sector has had to step into these areas. So absent the private sector, I am almost certain that we will not have sort of the quality of education that we have locally. That's more or less now gone completely into the private sector. And so companies such as ours, such as CarePay, I think are really stepping into a situation where a public good could have done. And we are doing that also because we believe that we are also creating a complete social good. The third point to make is that, a more general point, is that markets have discipline. Okay, and that anyone who steps into a market anticipating that they will make long-run superior profits, I think is making a mistake. Anytime there are big superior profits, even for a short window of time, capital will flow in that direction to make everything equilibrium-like. So now, having said that, let me now go into point number two. Of your question. Our whole ethos essentially is to bring together the marketplace, okay? Because of technology, the marginal cost of reaching virtually everybody has come down to zero. Everybody who has a mobile phone is reachable. Not only is that person reachable, that person is knowable. And that significantly reduces or should reduce the cost of access. Okay, now if the cost of access is reduced, it means the market should spread or widen. And if the market spreads or widen, we should have better underwriting and better products, and products that are competitively priced in such a manner that the people at the bottom of the pyramid can actually buy those products. What tends to happen now on the, let us say, on the underwriting side by the payers is because in the past they couldn't reach the mass market, quote unquote, they would only develop product for the corporate market. Okay, and if you were a retail person and you wanted to buy insurance for yourself and you didn't work for a big corporation, they would sell you basically a corporate product because they could not underwrite to the retail market because they couldn't get distribution. What CarePay is doing, it's signed up partnerships agreements in the countries that we're operating in with the largest telco companies in those markets, for example, and that should allow for explosion of distribution and discovery. And on the back of that, we've also signed up agreements with a number of payers or insurance companies to now create retail products that are priced for the retail market, okay? And they're priced and designed for the retail market, and that those things are put on our platform, and through USSD shortcode, 3 or 4 clicks, you should be able to have insurance for yourself and your family if you were a trader in the marketplace. and you don't have to go and buy a product, a corporate product. You can buy a retail product designed specifically to your wallet. So, and then on the demand side, we are working with a whole host of payers, of technology companies to create healthcare wallets that allow you save towards these products, so that you're not caught unawares, because the issue that I raised earlier is real. Okay, the beneficiaries do not trust that at the point where they need care, that they will access the quality of care that they paid for. The provider does not trust that if he puts in a claim, the payer will pay him promptly. The payer assumes the provider there's fraud in the claim, all kinds of things. And some company outside of the government has to set up a platform that allows for this transparency. And if that platform works perfectly and is transparent and there's more data, companies like Dorien's Medical Credit Fund can step in even on the supply side and fund providers, because they can see the flow, they can see the data, they know how many claims or how many interactions happen in a provider store. That allows for capital to flow in on the supply side, which improves the quality, which then allows for better trust on the patient side, and the whole thing should spiral upwards. I don't know that a government can step in and do this. I think that it needs private sector, private capital, visionary that's patient and long-term, to create the system that allows for this sort of inclusion at the levels that we just talked about.
Thanks so much, Amaechi. I think great points. You're saying there is a market out there where the public good can meet also the opportunities for private sector to step in, simply because there's such a scale. And I think nobody is arguing that there is not a scale when it comes to the Nigerian health market. So I think that is where the two meet, and you're arguing that the opportunity is really there with companies and African companies like yourself. But how could you then motivate the government to uptake technology? Is this something that you have seen a barrier, or do you see really that the government is ready to take PPP approaches in the uptake of technology?
Oh, yeah, absolutely. Actually, we are working with a number of government agencies to use technologies that we have developed and the partnerships that we have created to disseminate and reach a wider market and manage their universal health coverage schemes. I think that governments are fully aware nowadays that leaving things completely in the hands of the private sector, can skew things. So they will step in, they will make laws, they will facilitate those laws, they will create the agencies that help make those laws possible, and then they have to partner with technologies or technology companies for mass reach. So our view has always been, yes, we are open, and we continue to make work with governments who have recognized the need for universal health coverage access, and who also recognize the fact that you can't do it without technology. As a matter of fact, technology is the only thing that makes it now possible.
Okay, thanks so much. So you do see uptake in PPP approaches. Thomas, you're going to ask a question.
Yeah, I wanted to add something to that question of technology adoption by governments. So two quick points to make. One is, so technology almost automatically means data as well, or information, if you like. And there is... In many countries, I mean, in the developing world, in many countries, there is not really a good data governance. Yeah, so it's really quite unclear who owns data or who gives licenses to use data. So I think that, especially in the healthcare sector, which of course is data heavy on both the supply and demand side, I think that would be could be a factor to address. Yeah, in particular, if people were encouraged or even empowered to some extent to say, look, my health data is my health data, and I decide who gets to use that. And if I think the government is not doing a good job with that data, then I don't allow the government to use it. Now, that, of course, doesn't solve the entire problem of technology adoption. I do actually also think technology needs to become cheaper for governments to really adopt it on a mass scale. Yeah, that's easier said than done. That's where, for example, someone like us, FSD Africa, from the finance perspective, or in the finance sector at least, is very happy to support. But for government mass adoption of technology, I think the cost of it needs to come down, in addition to many other things, capacity, etc. But cost is definitely an issue.
Yeah, great points, Thomas. And maybe if I can tag on to the comments that you just made, because we've heard the private sector say we want to reach the poorest of the poor and the vulnerable. We've heard the government say we also want to reach that. And yet we know that there is this huge gap in financial health inclusion that is only widening at the moment rather than becoming smaller. So how do you see the role of FSD in this? How do we make sure that digital doesn't create a bigger divide, but is narrowing the divide?
Digital creating a bigger divide. So ultimately, I think it's a governance problem. Yeah. So I don't want to say we don't think we have a role in this, but it is something where governments need to step up. Yeah. And of course, there's plenty of support, at least in principle, available from various development partners, including to some extent us. It's not really our core area of work. But our core area of work is more with the financial sector, both on public and private challenges. But let me give two examples here of the kind of work that we do. One is in Ghana on the public healthcare financing side. We actually work with Farm Access on that, where there is an engagement with the National Health Insurance Scheme in Ghana to improve data analytics capabilities and make better use of data to understand what really could be done in terms of financing flows, in terms of structuring of benefit packages, etc., to achieve better healthcare outcomes. Yeah, I mean healthcare that is being paid by the National Health Insurance Scheme, and ultimately that achievement will then rest on a better transparency of what is actually happening in the system, both from a supply and demand perspective. And it will, of course, create efficiencies as well. So that's the cost angle. But ultimately, this is more about value, which will then drive attractiveness and relevance of a national public healthcare financing system for people, so that they sign up for it and make use of it and actually get better value out of it. The second example I want to make is, so we are in discussions right now with a private insurer in East Africa, which is already insuring a quite large number of relatively low-income workers in the private sector, factory workers, security guards, these kind of income groups. And they are providing health insurance already. But of course, them being an insurer, they come in when people have been sick and sought healthcare. And now they want to look at getting involved in what an insurer would call risk management and what a healthcare professional would call preventative healthcare. Because the hypothesis is that if the insurer would already help people to stay healthy, that is, of course, a benefit to people, but it also reduces claims incidents and claims cost for the insurer, which will allow them, this is what we're going to test, but still, I think it will allow them to reduce premium and perhaps lower it to the extent that it becomes affordable and attractive for perhaps even lower income people. And we are going to work with them on the data analysis, but most importantly, actually on the interventions, the digital interventions, think behavioral incentives, think digital healthcare technologies, and integrating that with the business processes and the business analytics of an insurance company to really make that case so that it can be adopted on a large scale and approved by the board of this company and perhaps also other companies then.
Yeah, great points, Thomas. So you're saying as FSD and as organizations to play a role to set the ecosystem and develop the business cases and to show the how-to, but making sure that the poor and the vulnerable are protected is a role of the government. It's also a question from the audience. So Mohamed, being the government panelist, can I ask that question to you? How do you see that role of the government in using that technology to address the very poorest of the poor? How do you use that in your current setting?
Well, the government first of all, let me talk about the importance of data. I'm declaring the importance of data for decision making. Data is power, and we are using systems first to enhance performance of our work, but on the way we are collecting data for decision making. And data is power. So if you don't have data, actually you don't have right to say anything. Maybe let me give you a brief history of how we started after Zanzibar Revolution. Soon after the Zanzibar Revolution in 1964, the government decided to provide free healthcare services to all Zanzibar community. The idea was intended to make sure that everyone is getting healthcare services without any kind of discrimination. But due to the various reasons, including population growth, immigration, and many others, changes of disease patterns, such as from communicable to non-communicable diseases, emerging of new diseases such as COVID-19, the available resources have not been sufficient anymore to provide healthcare services. In Zanzibar, we use insurance management information system that's used to capture service utilization data. So we recently conducted some data analysis from the system, where preliminary results from 2 districts, from South Unguja and Mkoani Pemba, shows that 7% of service consumers are having a kind of insurance, but they are still provided healthcare service for free of charge because the policy of the government of the country does not allow charging, or so there is no way you can use this insurance. So in spite of those having a kind of insurance, but they are still given free healthcare services. So you can see that all the money is benefiting the companies only. So when we look at the cost of the services they have been utilizing, we found that from January to September 2021, the cost for those 2 districts was over 100 millions. This amount could be enough to buy drugs for 60 years population. So only for that particular time. So by using this data, the government is currently revising her policy of health financing policy by incorporating health insurance. So that's the importance of data. So after having a policy for over 60 years that free healthcare services, but government now is thinking of changing the policy to include a health insurance. Thank you so much.
Thank you so much, Mohamed. And I think great examples of showing that it is not only about using technology to reach the poor. This is how you identify them and make sure that they are included and really embedded in your UHC approaches. So I think some very powerful information there that I'm sure the audience will be excited to learn from. Dorien, I know the Medical Credit Fund is also very much caring about making sure that vulnerable or marginalized are able to access healthcare services in the facilities that you are supporting through, especially this digital lending product that you've recently developed and won an award for. Can you tell us a little bit how that works? Why is digital lending so important to reach those healthcare facilities? How have you done it? And how does that target inclusivity when it comes to UHC?
Thank you, Nicole. I first wanted to make a statement, and that is, I don't think governments have a choice. mobile technology is overtaking already, and mobile money developments in Africa are overtaking the economy. So they don't have a choice; they have to come on board, and especially on the financing side, these digital financing streams open great opportunities, and that's also what we have seen some years ago, and also in partnership with CarePay and M-Pesa in Kenya, where we have developed a digital lending product. So the product is based on mobile money payments that are made in clinics, that are made in practice in clinics and all over the country, all over Kenya, and all over other countries increasingly as well. And we use these cash flows that are visible, can be made visible to us. We use those to assess what kind of loan a healthcare facility could qualify for, and we use it also to make sure they can repay the loan, or they repay the loan automatically. And this has allowed us to develop a product that is where healthcare facilities can borrow money from us without putting any collateral on the table. So that the borrowing is purely based on us seeing those cash flows. So I think it has multiple advantages. One of the advantages is that it's very accessible, it's easy for the facility, but it can also reach to really small facilities in the middle of nowhere, as long as they have people coming into the clinic paying with their mobile phones, which happens all over the place in Kenya. You can buy a mango in the market with your mobile phone. That allows us to reach the far off facilities, but in the recent times also with COVID, it has allowed us to reach facilities when the whole country is in lockdown. So the facilities in the middle of nowhere are struggling because they can't access a bank. The banks are closed, but we were able to disperse digital loans to them, and that has helped them also to bridge any cash flow problems during that time. And we've seen over the past 2 years, we've seen our digital product go sky high because of the lack of access to other types of to funding. We've dispersed 50 million in the last 2 years alone in digital loans in Kenya. We're expanding that product to other countries, but I also want to allude that we also expand digital lending to other products. We've done so in Ghana with the National Health Insurance, where we use the payments to clinics from the National Health Insurance as the underlying cash flow to lend against. And we also worked with the National Health Insurance to improve the digital processing of those claims, because that is ultimately going to be the driver for making more financial products possible. So I think there's such immense opportunities in the fintech sector that allow us to reach to smaller clinics. But as Amaechi also thought for CarePay Nigeria, it also allows inclusion of many poor people, because the amounts can be very small, the transaction cost becomes smaller. So it is an enabler of reaching the poor and underserved. I see we have 15 minutes left. Nicole, you maybe want to do other things or challenge.
No, I think it's a great. I think great points that you're raising, Dorien. You're saying that, look, it's not just about getting healthcare patients to healthcare facilities. Private sector facilities have a role to play. This includes small healthcare facilities, even pharmacies maybe, that you are able to finance through your digital lending products. And these are facilities that may not have the know-how and the capacity and need a loan large enough that they can go to a bank, but they can go directly through their mobile phone and connect to you. Because I think that's a question from the audience, people asking, what happens if a healthcare facility doesn't have technology? But I think you're just using a simple phone, isn't it? Maybe you can say 1 or 2 sentences about that.
Yeah, no, it's just a simple phone. It doesn't even need to be a smartphone. It's mobile money runs through feature phones, so the phones used everywhere in Africa. And what we do see also is that some healthcare facilities use the loans to purchase some digital tools in the clinic, so to improve their management by using technology. So that, I think, is an important. I would encourage every clinic to do so, to get more insight into their own business by digitalizing it. But that's, say, access to the digital loans is not restricted to high-tech technology. It can be done on a mobile phone.
Yeah, so you're tapping into technologies already there, rather than just designing something new. Thomas, you have some opinions about that. Keen to hear your thoughts. Should everybody get a mobile phone in the healthcare system in Africa to accommodate all this?
Well, to be honest, I think virtually everyone already has a mobile phone. I mean, if you run commercially a pharmacy or a small healthcare facility, you have a mobile phone. Perhaps you only have a mobile phone, actually. No, I wanted to add something about this, what Dorien was just talking about, the mobile money-based lending and payments and so on. I mean, what this illustrates, of course, is, and you mentioned it, Dorien, lending against cash flow. Yeah? But you will only be able, or a bank, a financial institution will only be able to do that, at least at scale and then commercially sustainable, if that is digitally and through that somewhat transparently available. Yeah, and the beauty of mobile money is that it makes that transparent and that data available. So definitely big opportunities in that, but also a risk. So we see that, I mean, I live in Kenya. I see M-Pesa, use it every day, but it's a bit of a walled garden. Yeah, it's one system that is owned by one company, and it has had a fantastic social and economic impact in Kenya. Yeah, but it comes down to the question who owns that data and who monetizes that data, and of course it's a commercial enterprise. So to some extent that is fine, but when it comes then to enabling access and financing of social services, I think there is a question of at least partly making data and analysis that you can glean from that more widely accessible, at least parts of it, so that additional commercial and even non-commercial but socially beneficial services can be built on that, which I think is particularly important if you want to extend it to the very poor, the very low income segments.
So when it comes to limitations and risk of losing data and technology, is it about data privacy? Is it about monopolizing certain products and services? And what can be done to overcome this?
So can I say one, two? So I think it is. I mean, I'm not saying it's the only question, yeah, but it is. I think it is a question. I mean, in the developed financial systems, yeah, we now see a very strong drive towards what's called open banking standards and the like, precisely for the reason to expand people's access to innovative financial services. Yeah? And I think that's a valid discussion to have also in Africa and other developing regions. And as I said, in particular, when it comes to using that for social services, healthcare, education, payments, etc. Then I mentioned before data governance, so I'm not going to go into details on that, but the ownership and then I mean also the right to commercialize data is important, both for the producer of that data, the people, as well as for companies. Yeah, I could also give you examples of companies that are actually shying away from building financial services on top of data because they just can't be clear, or it is just not clear whether they're allowed to do that. Yeah? And then I think what we will also see is increasingly the question of how acceptable to people it is that their data is being analyzed. Yeah? I mean, that's definitely there in the developed world, and it's increasingly. I mean, it's going to come to emerging markets as well.
Great point. So data is both a challenge as an opportunity, but I think we also need to be realistic that data is going to happen. It is the future, and we need to understand how we use it for a public good. Maybe, Amaechi, can I ask for some of your experiences, brief, because we don't have a lot of time. How can you get the data actually to feedback and use it for healthy behavior of the individual who owns and the data belongs to? What is your experience in that?
Thank you so much, Nicole. That's a really good question. Let me just start by saying one of the overarching things we do at CarePay is that we spend a lot of time interrogating each other and interrogating ourselves around what specific benefits do we bring to each participant in the market, direct or indirect. Okay, and it always comes down to, of course, market access, but data is a crucial part of it. Okay, data is something that can be used both by the owner of the data, by the government. The governments can use data, of course, and they are participants in the whole healthcare ecosystem. Even if they are indirect, they are huge beneficiaries of a healthy population. And data allows them make much better healthcare policy decisions. Okay, it helps them figure out how they channel their capital or their policy decisions one way or another. Without data, they're shooting in the dark. It helps the patient because you can better advise them, better target healthcare products for them, better help them manage their health. It helps the providers because they can resource allocate. And just like Dorien said earlier, that you can only size and tranche the loans and the repayment terms to providers because you have data. And because now with their mobile phones and low code and low tech, they can actually access this data. It helps the health insurance companies and the payers because now they can better underwrite products. They can better price them and develop and design them and target them at very specific segments of the population. So everybody benefits from data. Now, data and technology also has a downside, of course. Okay, I mean, I can give you one unrelated to healthcare, for example. With mobile telephony, for example, kidnapping went up in my country, Nigeria. Okay, absent the use of mobile phones and the ease with which it is to contact and collect ransom payments, I bet this industry would not exist. Okay, or at least not on the scale that it does. Okay, so the reality is that everything has a downside. And it needs governments and players and participants like ourselves to think through in detail, okay, the potential downsides of these things and to minimize them, okay? And part of what we also do at CarePay is to try to figure out how we don't abuse data and how we, if we are entrusted with it, how we protect it, anonymize it in such a way that it's not abusable or commercializable, okay, in the way, say, a Facebook might seek to commercialize its data and have targeted advertising to people. This is not our ethos at all.
Great points. Thank you so much, Amaechi. We're entering into the final minutes of our discussion. I actually want to give everyone a short round of final comments in 2 sentences. But Mohamed, I want to start with you, and I'm going to give you a few sentences more because you've heard the private sector talk. There's a huge opportunity here. Obviously, Zanzibar has started great with already setting this digital e-health strategy framework. What's your future going to look like in Zanzibar?
Thank you so much for this great question and great opportunity to share the future thinkings. Like I said, we have just started. We are transforming from manual systems to digital systems, where we believe that the change of the move we are taking has great impact, specifically in the health sector. But we need to have a management change, because transforming from paper-based and to digital systems we are like in transition, which is not reversible. Once you leave out the paper-based systems and transform to digital systems, you actually need to get prepared, because this is irreversible change. You cannot have moved from, once you leave the paper-based systems, you cannot come back to it. Examples, we are having bankings that are now using digital systems. When the system is down, there is no way you can get services from it. And for us, which we are providing healthcare services, you cannot go to the hospital, and when the system is down, and you are told go back and come back tomorrow when the system is up again. So we actually need to get prepared, so that when we move from paper-based system to go to electronic systems, we need to be very sure that we are sustaining the development, so that we get a continuity of services. This is including both private and government sectors. Thank you so much.
Thanks so much, Mohamed. Great vision. Change is inevitable. It's going to happen. Have the government make sure that the country is prepared for it and is leveraging this. I think very powerful words. 2 minutes on the clock. I'm giving everyone one sentence or final comments. Thomas, starting with you.
Yes. So really very quickly. So I think for digital technologies to improve access and financial access, actually, there's a couple of systemic issues or systemic questions to resolve. Because suddenly you have the digital economy, if you like, interact with the financial economy and the healthcare economy, and the linkage points aren't always very clear, especially on the policy side. And then there is, of course, a tremendous commercial opportunity, and with that, actually, is opportunity for social impact by having these different economies work together. And there's a lot still to be done, but there's also a lot already happening, and I find this very exciting, and I love to work in this space. Yes.
Great, Dorien, one sentence.
One sentence. I think we should make sure that we use the digital technology to connect both the demand side, to address both demand side issues and supply side issues, and connect them. And the same is probably true for private and public sector, that we make sure that they, through technology, can complement each other better.
Thank you.
And I think there's tremendous opportunities going forward.
Great. One sentence, Amaechi.
Well, thank you so much. I'd like to say that I think the work that CarePay is doing in the markets that we operate in is really visionary and difficult. And it's very hard to step into this kind of holes or into these kind of gaps where you do have to create the platform and the infrastructure that enables trust and that enables transactions and interactions in a whole ecosystem to operate seamlessly and with trust and visibility, and that the work that we're doing is really visionary. It's difficult, it's hard, it's long-term, it requires pulling in all kinds of partnerships and people, and it's almost a chicken and an egg type of situation. Do you get the patients first, or the providers, or the payers first? And so everything has to happen almost at the same time. And that CarePay doing this is really, really, really doing some visionary work. We hope that in a few years' time that our work pays off.
Thank you so much, Amaechi. And let me, with that, end this session, but not before thanking my wonderful panelists for a very interesting, very stimulating discussion. I think a lot of food for thought. The journey has only started, and we look forward to catching up on the next panel and see the impact we have made. Thank you, everyone. Thank you to the audience for joining today. Thank you.
Thank you very much.
Thank you. Thank you.